All right, today we're diving into a topic that is absolutely essential for any clinician, pleural effusion. We're going to break down the whole thing, from the very first signs all the way through to management. And we're going to start exactly where it all begins, with a patient. So, picture this. You're in the clinic, a patient comes in, they're short of breath. You do your examination, and when you percuss their chest, you hear this really specific sound, a stony, dull thud. Right away, that classic finding should make one diagnosis jump to the top of your list, pleural effusion.
So here's how we're going to tackle this. We'll start with our patient, then we'll peek inside the pleural space to see what's really going on. We'll cover the huge difference between transudate and exudate, walk through the diagnostic steps, and then wrap up with how to manage it. Okay, let's connect that clinical sign, that stony dullness, to the big question. What exactly is a pleural effusion? What's happening inside that patient's chest?
It's actually pretty simple. A pleural effusion is just an abnormal buildup of fluid. This fluid collects in what's called the pleural space. Think of it as this super thin potential gap between the lung itself and the inside of the chest wall. When too much fluid gets in there, it starts to squeeze the lung, and that's what causes all the problems. Now, it's really important to know that this space isn't totally empty to begin with. You've normally got about 10 to 20 milliliters of fluid in there, just enough to act like a lubricant so the lungs can slide smoothly when you breathe. And effusion happens when that perfect balance gets thrown way off. So why does that balance get disrupted? Well, if we understand the why and how behind the fluid buildup, we're already halfway to figuring out the cause and the treatment.
It all boils down to a plumbing problem, really. Fluid builds up for one of four main reasons. Either you're pushing too much fluid out of your blood vessels because the pressure's too high, or you don't have enough protein in your blood to hold the fluid in. Another reason could be that your vessels have become leaky. Or finally, the lymphatic system, which is kind of like the body's drainage system, gets blocked.
And those mechanisms lead us to the single most important question you have to answer when you see a pleural effusion. Is this fluid a transudate, or is it an exudate? Getting this right determines everything you do next. So here's the difference. A transudate is caused by a systemic issue, a pressure problem throughout the whole body. Think heart failure or liver cirrhosis. It's a mechanical issue. An exudate, on the other hand, is a local problem. It's caused by inflammation right there in the pleura, from something like an infection or a tumor making the local blood vessels leaky. Okay, so we've got these two very different buckets with totally different causes. The million-dollar question is, how do we look at the fluid itself and figure out which bucket it belongs in? The answer is Light's criteria. You absolutely have to know this. It's a set of 3 simple rules. We basically take the fluid from the chest and a blood sample, and we compare the levels of protein and an enzyme called LDH. LDH is a marker for inflammation or cell damage. These numbers give us a biochemical fingerprint that tells us exactly what kind of fluid we're dealing with. And the rule for using this is beautifully simple. If your fluid meets just any single one of these 3 criteria, it's an exudate. That's it. If it doesn't meet any of them, it's a transudate. This is such a powerful tool for narrowing down the cause. Now that we know what we're looking for in the lab, let's step back and walk through the entire diagnostic process, right from the moment that patient walks through the door. So we're back with our patient. They're breathless, maybe have some chest pain. And on exam, we find that classic stony dullness again. We'll also hear decreased breath sounds and feel less vibration on their chest wall. All of these signs point to the same thing. There's a big pool of fluid in there, basically muffling everything. So to confirm what we suspect, the first thing we'll do is get a chest x-ray. What you're looking for is a blunting of that sharp little corner where the diaphragm meets the ribs. As more fluid builds up, you'll see this beautiful curved shadow called the meniscus sign. It's a dead giveaway. Now, an X-ray is great, but ultrasound is actually even better, especially for catching smaller amounts of fluid. Plus, it's the perfect tool to guide us if we need to put a needle in there, because we can see exactly where we're going in real time. And that brings us to the key procedure itself, thoracentesis. This is where we insert a needle into that pleural space to draw the fluid out. This is so important because it's both diagnostic, we get that fluid to send to the lab, and it can be therapeutic, meaning we can relieve the patient's symptoms by draining it. The procedure itself is pretty straightforward. You clean the area, numb up the skin really well, and then you carefully insert the needle. The key thing to remember is to go just above a rib. Why? Because the nerves and blood vessels run right underneath the rib, and we definitely want to avoid those. Then you just slowly pull out the fluid and send it off for analysis.
Okay, so we've confirmed it, we've classified the fluid. Now for the most important part. What do we do for the patient? How do we manage this?
And here it is, the absolute golden rule of management. The pleural effusion is just a symptom. It's a sign that something else is wrong. You have to treat the underlying cause.
So you see how it all connects? If you diagnosed a transudative effusion from heart failure, you treat it with diuretics. If it was an exudative effusion from pneumonia, you treat it with antibiotics. The management plan flows directly from that crucial transudate versus exudate distinction we made earlier. Of course, if the effusion is huge and the patient can't breathe, we'll drain it just to make them feel better. And we always have to be mindful of what could go wrong. If an effusion gets infected, it can turn into an empyema, which is basically a collection of pus. A really massive one can cause respiratory failure. And over time, chronic inflammation can lead to scarring, which can permanently trap the lung. So let's wrap this up with the key takeaways. Pleural effusion is an abnormal collection of fluid. The number one step is figuring out if it's a transudate or an exudate using Light's criteria. We diagnose it with our exam, remember, stony dullness, imaging, and of course, a thoracentesis. And finally, always treat the root cause. We'll end with one last question to get you thinking. You've done everything right. You've followed the whole pathway, but then the lab calls. The fluid has malignant cells. How does that single piece of information change everything? Well, that discovery opens up a whole new diagnostic and management pathway, and that's a story for another time.